Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Authors Forum podcast. It's my pleasure to welcome Dr. Warren Sobol, Associate Professor of Ophthalmology at the Case Western Reserve University, to discuss their case, Early Presentation of Successive Acute Retinal Necrosis decades after initial infection. Welcome, Dr. Sobol.
Thank you. Thank you, Tim, for the chance to be here.
So you have a fascinating case, and I think it's illustrative of many key critical points. Could you briefly give us an overview of the clinical presentation?
I'd be happy to. This very, very pleasant fellow presented to our clinic with a lot of floaters and blurry vision in his only eye, and he very rapidly told us no reason to look at my other eye because the same thing happened 20 years ago on that side. And golly, doc, I had a whole bunch of treatments and a whole bunch of surgeries, and I can't see anymore, and I've only got one good eye. Is there any way you can help me? So when we look at him, he has a pretty significant uveitis, both anterior and posterior, and some interesting sort of suspicious looking areas of white fluffy material in the retina, a retinitis, little spots, not really classic for anything, could be a lot of different things. And we're, of course, naturally alarmed at that. And when I talked to him a little bit more, he says they might have even used the term retinal necrosis for my other eye. Well, that sort of harkens to the age-old dictum of medicine. The patient will tell you what the diagnosis is sometimes. If you're lucky, of course, you got to listen to them. And sure enough, that got us thinking, even though it doesn't look classic, and even though it's been 2 decades since his other eye, maybe it's a case of ARN. And of course, that raises all the red flags that we need to do to make sure it doesn't progress. It's something that's going to progress rapidly, and everyone knows that looking at this forum here. And of course, he needs the full workup, a uveitis workup. I'll say, once upon a time in a different era, there wasn't a uveitis specialist at your beck and call. You were the guy, and now we have wonderful uveitis coverage here in Cleveland. And my colleagues at the university are just fantastic to work with. Can't thank them enough. And yet, even then, it still doesn't look classic. We do a lot of workup. All of it comes back negative. But I'm looking at this thinking, this looks like early acute retinal necrosis. It hasn't yet coalesced into the diffuse retinitis that is much more easy to diagnose. And we better do something, and we better do something quickly. And that is, in general, the presentation at the moment.
So, Warren, when you see this gentleman, he's a little bit older. He's in his 60s. He doesn't have a history of being immunosuppressed by the common denominators that we look for. And without his telling you what he had thought he had before, this could have been a very different evolution of the evaluation. But triggering you to think in this very specific way, what was your focus on best diagnostic testing to try to push you forward while you considered treatment?
Aside from the usual labs that we all need to get, I think an anterior chamber tap for PCR is really the gold standard to making this type of diagnosis, and we immediately wanted to do that, and we did. Of course, it's not so simple. Real world life isn't so simple sometimes. PCRs take a little bit of time. Sometimes you get an error message from the lab, not enough sample. Sometimes it didn't get sent right away. we try to get around all of those things. And then the literature is clear that it's not always positive. It's might have a lot of specificity, but it's not always sensitive. And so PCR, I think, is the immediate thing that went through everybody's mind here.
So knowing that you were going to do a PCR and all the caveats that come with the PCR, and this is his only eye, which is inflammatorily involved already, do you wait for a potential answer, or are you thinking we're going to treat immediately and then come to the specimen?
Yeah, Tim, immediately, if not sooner. I think there's such a small window of potential success here. And even in this case where we started treatments, and we could talk about that and what my thinking was when we were doing it, and also my colleagues who were on the case report as well, and really grateful for their help. Um, the immediacy of treatment is, I think, the real major focus of this type of case. I think that it's not yet classic, that there's a small window of treatment where it's going to work. And even after we started treatment, even then, there was still some progression of the lesions that we were very concerned with. So, yeah, early treatment.
What are you thinking about treatment? Because there is some controversy as to the best way to approach this, and you made a very reasonable choice in my mind. Can you tell us a little bit about that thought process?
In my mind, starting with the oral medications, Valtrex type medications, trying to get blood levels, and there's good data for that those are sometimes very, very much treatment specific for this. We're going to assume that it's ARN until proven otherwise. We're starting treatment, and what are we going to start with? In my mind, oral use of valcyclovir was the way to go with this. And in the higher dosages, which have just over the past 2017, over the past 7 years, have sort of become accepted in the literature, whether you believe it's 2 grams TID or 2 grams QID. You can debate, but you need to give a lot more than just 800 milligrams of acyclovir. But that's my first thought. Let's get that loaded, get that in place, and also consider pretty quickly an intravitreal injection of some sort.
And so intravitreal has become really a mainstay of our therapies here. What medication are you thinking of specifically injecting here?
I think has become almost everyone's accepted that foscarnet is the go-to medicine of choice. I have to admit, at first glance here, I was a little concerned with more CMV, so I chose the very first time around ganciclovir. That, of course, didn't do much. But then very rapidly, as the lesions started to coalesce and look a little bit more like more classic ARN, I immediately, if you will, pulled the string and started injecting every 2 to 3 day foscarnet.
And then, so now you've got foscarnet, you're doing oral. There is some contentious discussion about steroid and then the supplement of a potential laser. So what were your choices, and how did that fall into this treatment paradigm?
Tim, at this point, he still didn't really turn the corner, and we admitted him for IV acyclovir. And then all of a sudden, things did start to turn the corner very nicely, very rapidly. And other than topical steroids, because he was clearing nicely, I felt it'd be best to just stay the course, and then to wean down the foscarnet to half dose, and then do that every 2 to 3 days, and then try to make a clinical judgment call as best I could, and with the help of my colleagues, to not using the steroids other than topical use. And the issue of laser, I think, is still really really on the back of my mind and really bothering me a little bit here. And that is, in my career, I've seen a few of these cases, and there used to be a hard and fast rule to do a laser around that necrotic retina because it's potentially going to detach and be the little slit tear complex detachments that sometimes require silicone oil. We certainly want to avoid that if we can. And I did not then or now do it. And I'll say we're almost 2 years out from this presentation, but I have him coming back frequently, and I have him on oral Valtrex, valcyclovir, as a maintenance, even now 2 years later. And I accept the fact that maybe that's not the right decision. I talked it up a little bit to some of my colleagues, and I appreciate their thoughts. And I think the majority said don't touch it with laser, but I wouldn't have disagreed, and I could have been talked into it. Let's put it that way.
One of the things I think is important is in these unusual cases, we have to use best judgment. And there's often not a clear right or wrong answer. There's a lot of controversy about laser. There's been recent discussion of early vitrectomy, primary mechanisms for diagnostic testing and then treatment. But the bottom line is you're 2 years out of someone who has only one eye with an acute retinal necrosis and has maintained the eye and good function. So to me, the proof's in the pudding for this. You made excellent choices along the way.
Sometimes it's better to be lucky than good, but
Yeah.
as the old saying goes, um, there used to be, even when I was a fellow, an idea of putting acyclovir in the infusion line and doing a preventative vitrectomy on presentation. I don't think anybody does that now, but I remember that, and I certainly understand the rationale for it. But in any event, you're right. I was probably lucky, and again, with the help of my colleagues and also the residents involved in the case, one of the residents is now a uveitis fellow with our colleagues over at the clinic, and we're so happy for her. And yeah, so you're right. It does end up looking very good, but I can't sit here and say that I was 100% sure at all times.
And then the other thing just to come back to is you really stated this case nicely, but how important the history was here. And I think in these complex inflammatory diseases, they demand a history very different from what we look for in our standard surgical retinal detachment patients.
Well, I couldn't agree with you more, and maybe because of my age, the residents look to my grayness here and see that, and hopefully that'll echo through the next generation. But I again, I totally agree with you. And the old dictum, I think William Osler said it best: you're supposed to listen very carefully because they'll tell you what's wrong. And he sure had the right story, and he even had the right words, and so that did help because it certainly made it a lot more easily justified to very aggressively go after this. So, yeah.
Well, Dr. Sobol, thank you so much for joining us. I refer all of our listeners to your full manuscript, which is really elegantly written and has some excellent imaging. So thank you. I know the weather is not quite as warm for you as it is here,
Nope.
but I'm glad you could find your time to make it to join us. Thank
That's
you
my
so much.
pleasure, and thank you to everybody at ASRS, and thank you for all the things you're doing at the in the journal. It's wonderful to read. I read it carefully every time it shows up on my doorstep.
We really appreciate that. Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.